Hey, this is Brad Smith, the director of the Center for Medicare and Medicaid Innovation, and I'm really excited to be joining you guys at the Better Medicare Alliance annual conference. Sorry we're not able to all be together in person this year, but really excited to update you guys on all the great work that we've been doing at CMMI and at CMS over the past year. And just want to thank you before I get started for all the support that you all have given to us across all of our models, whether that be our Medicare Advantage VBID model, where we allow for flexible designs in Medicare Advantage, whether that be direct contracting, but all of your members have been great partners to us. We appreciate all the feedback that you constantly provide. And I just want to say thank you before I get started. But it's been a really full year. Obviously, we've spent a lot of time working on COVID. We're excited about the progress the country is making around building up our PPE supply, building up our testing, building up our therapeutics. But today, really want to talk about the work that we've done at CMMI. And in particular, want to talk about three different things that we've done. First, want to talk about a review that we did early in the year to talk about lessons learned. And what we did during that was go back and look at all of the models that we've done over the past 10 years and really try to capture what went well, what are some opportunities that we can learn from. Second thing I'll talk about is some of the models that we have launched this year and how those are going. And then third, we'll talk a little bit about some of the things that are coming down the pike for next year. So let me start by talking a little bit about the review we did. So CMMI started almost exactly 10 years ago. And over that time period, CMMI's launched 54 different models. So when I came in, one of the things that Administrator Verma asked me to do is to work with the team and to go back and look at how those 54 models had gone. So we started that process back in January or February. Obviously got a little distracted in March or April, but we're able to wrap that up by April or May. And I think we had some really interesting learning. So there are some things that have gone really, really well. So for example, we've had incredible participation in our models. Over 1 million providers across the country have participated in our models. The models have delivered care to 26 million Americans, so almost a little bit under 1 in 10 Americans have been part of one of our models. And I think we've really focused on making sure that as we start this transformation to value-based care, that we really have robust participation. I think by all accounts on that metric, we've been incredibly successful. I think we've also learned a lot. So out of the 54 models, when we look at our evaluations, we find that about 5 of the 54 have actually produced statistically significant savings. And here at CMMI, we have 2 goals. One is to help lower costs by producing savings, and number 2 is to improve quality. The 5 models where we've seen the improvement in savings are number 1, our Maryland all-payer model. This is a global capitation model for hospitals. We've seen it help decrease total cost of care. Number 2 is our non-emergent ambulance transport model. It's essentially a utilization management model for non-emergent ambulance transport. A third model that we're really excited about is our home health value-based purchasing model. It's a model for home health agencies that provides a incentive either up or down at the end of the year based on their quality performance. We've seen in that model both really high amounts of savings and also some really significant improvements in quality. The fourth is our Pioneer ACO model. This is a model that was one of the precursors to some of the MSSP ACOs. And the fifth, which I'll talk a little bit more about later, is our AIM model, where we gave some upfront payments to rural and urban hospital systems to help them enter the MSSP 2-sided risk track and the 1-sided risk track earlier on. So 5 models that we've seen statistically significant savings in. Obviously, that we would have loved to see savings in more models, but I think we've actually learned a lot from the models that we haven't seen savings in. And actually, in a lot of those models, we did see gross savings, but we didn't see net savings, many times because of the amount of payments that we paid out to the participants in the model. And that happened really for one of 3 different reasons. One reason was in a couple of our models, like our primary care model and our oncology care model. We had pretty significant additional payments that we paid to the participants in those models to help support care coordination, either in the primary care or the oncology setting. And sometimes, for example, in the oncology model, even though we were seeing gross savings, when we take into account those significant MEOS payments, we didn't see net savings across the entire model. A second reason that we saw that I think we're going to be able to address going forward is sometimes our benchmarks in our models have not always been accurate. So our benchmarks are how we set prices for the models. We try to predict what the price will be at a time in the future. And what we found is that that's pretty hard to do. And I think through a number of the lessons that we've learned, looking at retrospective trends, thinking about how we do regional adjustments, thinking about how we do risk adjustment. We've learned a lot about benchmarks that we can really work on and continue to refine the models in the future. And I think a larger number will produce savings in the future. The third thing that we've seen in some of our models that have prevented us from getting savings is adverse selection. So this is especially true in models where we provide a lot of choice to participants, where they can, for example, in our bundles model, choose which episodes to participate in and which hospitals to participate in. And what we see, which is what we really should probably have expected, is that people are rational actors. They look for those places where they have the most advantageous benchmarks, and those are the places they participate. And there are a number of ways that we can kind of help address this adverse selection, and I'll talk about some of those that we've done around the bundles model later. But again, at a high level, I've seen 5 models have statistically significant savings, but I think I've learned a number of things about ways that we can have more of our models in the future save money. The second goal for the center is to really improve quality. And we have seen some really important improvements in qualities in a number of our models. Just as a couple of examples, in our kidney care model, we've seen a decrease in emergency dialysis sessions at a statistically significant level. We've seen a decrease in hospitalizations and a decrease in readmissions. In our home health value-based purchasing model that I mentioned earlier that has had significant savings, we've also seen a really significant quality improvement. On average, participants in the model have about a 4.6% improvement in quality scores relative to the control group. So I think we've had some really good successes, but as we move forward, I think what you'll see from us is us continuing to lean in to really making sure that our models are delivering on the goals of lowering cost and improving the quality of care. But let me talk now a little bit about the work that we've done this year at CMMI, and then I'll get to some of the work that's coming next year. So this year, in addition to going through all of our models and reviewing them, we also went through our entire operating budget. We're actually able to reduce our operating expenses by over $350 million, which is about an 18% reduction. This is really important for CMMI because it allows us to take that money and to invest it in future models that we're developing, which will allow us to do more models in the future than we would otherwise be able to do. In March of this year, we launched what we call our Part D senior savings model. This is a model intended to help lower the cost of insulin for seniors and select Medicare prescription drug plans. The way it works is that the maximum out-of-pocket cost per month is $35 in these plans. And currently in the open enrollment season that we're in, we've had, I believe, over 1,600 plans across the country apply to participate in this model. And seniors are currently being able to pick whether or not they're enrolling in those plans. And we thank many of your members who have been participants in this model. We're very excited, not only about what it can do for seniors around insulin next year, but we believe if the mechanism that we're using in this coverage gap works for insulin, there's a good chance that it may work for other drugs in the future. In June of this year, we also implemented a number of flexibilities around our models based on what we saw happening in COVID. Sometimes this included pushing back reporting requirements. In a few cases, we changed the start dates of some of our models. And in certain cases, we helped limit the risk that providers would have, especially downside risk in some of our models. In August, we launched a model that we're very excited about called our CHART model. And it's really focused on improving rural healthcare. Specifically, it has 2 different tracks. The first track will be us investing $75 million in 15 different rural communities across the country to help them transform how they deliver rural healthcare. In this model, we're giving a lot of flexibility to the rural communities. So as one example, for the first time, we're going to be waiving Medicare conditions of participation. And what that means is that hospitals will be able to really undergo really meaningful transformation. So for example, they don't have to have inpatient beds anymore. If they just want to become primary care, behavioral health, and an ER, they can continue to get the same rates they would get for those services as if they had inpatient services. And we think those kind of flexibilities will really allow these 15 communities to transform how they deliver care. And we hope that these 15 communities can be a star and a shining star for the rest of the country to learn from. The other part of CHART is what we call our second track, which is really based on our AIM model that I mentioned earlier. As I mentioned in our AIM model, we saw these upfront payments to allow folks to participate in our ACO MSSP shared savings program produce significant savings when we did it a few years ago, over $300 million of savings. And so in CHART, we're essentially doubling down on that. And now we're going to be supporting, I believe, up to 30 different ACOs across the country with upfront payments if they're entering our MSSP program in the 2-sided risk track. And so we're very excited about being able to support rural hospitals in that way. In September, we made a really big announcement, which was some changes to our bundles model, which we call BPCI. What we've been seeing is, based on some of those benchmarking issues that I mentioned before, that our current BPCI model was on track to lose over $2 billion. And while we're learning a lot and we're seeing some really changes in care, and especially people going to the home after surgeries versus going to skilled nursing facilities, that obviously meant the $2 billion of losses, that the model was not sustainable. And so what we've done starting next year is implement a number of changes, including moving from what was a prospective trend to a retrospective trend that will allow us to increase our savings by about $1.1 billion. And what that really means is that in the last 2 years of the model, we'll end up being break even. But more importantly than that, what we committed to as part of those changes was moving towards a mandatory bundle payment model. Our initial plan was to probably do that around 2023. The kind of feedback that we got from folks is making us look and see if we can do that earlier. Because what we heard from a lot of the participants is, hey, look, if you're going to move to mandatory, we'd like you to think about doing that sooner. And so we're going to take that feedback and see what we can do there. And then the final model that we launched this year is our ETC and RO models. Our ETC model is a kidney care model that's focused on incentivizing transplants and incentivizing in-home dialysis. And our radiation oncology model is a model that's testing bundled prospective site-neutral payments across different modalities of radiation oncology. We're really excited about both of these models, and they both go into effect starting probably around January. As we think about next year, we also have a number of models that are coming down the pipe that I want to just talk about a little bit. The first model is our direct contracting model. This is a model where we're allowing physician groups to take risk on their patients, either 50% risk or 100% risk. The team did some incredible work over the spring and over the summer to make sure that we had our benchmarks right, to get the risk adjustment strategy right. And we've posted all of the papers around the financial methodology online now. Our implementation period started about a week or two ago, October 1st, and our first cohort will be starting participation in the program in April of next year. Because of COVID, we know that not everybody is going to be ready to start next year, so we also created a second cohort that will allow folks to start in January 2022. So far, we're really excited about the enthusiasm that we've heard around direct contracting. The number of applicants that we had is higher than we anticipated, and so we're really looking forward to that model getting launched next year. Another model that we'll also be launching in April is our Kidney Care Choices model. It's essentially a sister model of the direct contracting model, but it targets folks with end-stage renal disease and chronic kidney disease. We've received over 100 applications for the model. We are in the process of finalizing the benchmarks and the risk adjustment papers that we'll post soon, but we're excited to get that model started in April as well. We also have two models coming down the pike that I wanted to kind of preview for this group. The first is what we call our direct contracting duals model. This is a model that would allow managed care Medicaid plans to take risk on their Medicare members who are not already in Medicare Advantage or in an ACO. The way it would work is that those Medicaid plans could come to us and apply, and they could then take risk automatically on the Medicare fee-for-service members using benchmarks that are very similar to what we're using for physician groups and direct contracting. The second model that we've been working on a lot this year is what we call our direct contracting geographic model. This is a model that would allow either plans or large provider groups to come in and take risk on Medicare fee-for-service beneficiaries across an entire region. They'll have the opportunity to offer additional benefits to beneficiaries, to offer lower deductible or lower premiums, lower cost sharing, lower copays, and in return, we'll give the DCE a tremendous amount of flexibility around things like care management, around things like additional benefits and programs that they can offer to help improve the care and improve the quality of beneficiaries. We'll also allow them to build essentially a preferred provider network where they can move with certain providers off of the Medicare fee-for-service rates. At the same time, we'll make sure that beneficiaries have access to every provider in Medicare, regardless of which DCE that they're working with. Maybe one last model I'll mention. I know this is a model that's especially important to your members, and again, we just thank them for their participation, and this is our Medicare Advantage VBID model. And this is where we test out different kinds of flexibilities in Medicare Advantage that we hope to be able over time to implement in the entire Medicare Advantage program. We're especially excited that participation is really up this year. In fact, going into 2021, our participation will have tripled from 157 plans participating to 451 plans participating. And now the MAV bid will be working in 45 different states across the country. In addition to a lot of the flexibilities that we've had historically, we are also implementing a new hospice benefit where hospice will be part of Medicare Advantage. We've actually heard a lot of great feedback from this from our Medicare Advantage plans, and we're even thinking, based on the feedback we've received, about potentially having another opportunity for folks to apply for 2022 if they're interested in having hospice be part of the Medicare Advantage program. But I think in summary, what we've seen is, where CMMI is we're 10 years in. We've learned a lot. We've had a number of successes. But as we think about the models that we have going on that we launched this year, and especially the models that we have coming down the pipe next year, what's really important to us is to make sure that we're driving the purposes that we were set up for. And that's ensuring that the models that we launch save money and or improve quality. And what we're confident in is that if we're able to have models that do that, that we'll be able to align other payers to participate in those models. We know that it's very hard for providers across the country to have one payer paying one way and another payer paying a different way. And what we believe is that if our models, we can prove that they're saving money, if we can prove that they're increasing quality, we believe that other payers will come along with us and will align with us, whether it's exactly or 80%, who knows, but we believe that that will significantly increase alignment and hopefully over the next 5 or 10 years, really help transform where the country is from a system that pays on volume to a system that pays on value. So just in closing, want to thank all of your members for everything that you do. Want to thank you for your participation in the models. Want to thank you for the feedback that you provide us and look forward to talking with many of you all soon. Thanks again.